I think Deca can also lower your SHBG.
I've had patients come in, not a whole bunch, but I've had bodybuilders that have used Nandrolone.
I mean, George tells the story of his 108-year-old grandmother.
Yeah, I mean, 84 to 88, it was 104 to 108.
So we're injecting her for 2 years.
It's not that you're using the same dose for everybody. A standardized starting dose is okay.
Nandrolone would be used as a sole therapy to avoid,
because your body still makes enough dihydrotestosterone.
what about some of the water retention that one gets?
Get through a workout and do the work to do, say, teres minor work.
I mean, where do you think a therapeutic dose, or maybe not just a dose, because the dose is highly individual. It's, I mean, where do you look at the trough? I guess you look at the trough level of testosterone. I think I've heard it was you maybe that said, what, 800 milligrams and above, or is there a particular number?
Back
Yeah.
in, I want to say the 50s even.
Or 800 what was it? 800 nanograms per deciliter, yeah.
They weren't even looking to free T back
Yeah.
then. So they use that now. Guys, and I mention him all the time because he's one of the leading guys. If you look at the papers in the United States, I mean, Dr. Lipschultz is included in most of those papers, and a lot of his fellows, Ramasamy, I'm going on, but there's plenty of guys out there that use the same protocols that arguably he developed.
He also uses aromatase inhibitor for the fertility protocols because it does something for the testes. I've got my own personal. I'm not promoting them because sometimes if you get it wrong, then as a result you feel really bad joint pains and too low. But I had noticed for many years when I didn't have HCG, and I've been on it for 27 years, the testosterone treatment, that. And it's anecdotal, but after using aromatase inhibitors, and at the time like you, I was on quite a high dose, I didn't get the shrinkage of the testes. In fact, they would feel a bit fuller after a bit of aromatase inhibitor. So again, that's my experience. I don't know if anyone's watching, if they've had that same experience, let us know in the comments. But yeah, in general, that's something I've seen. And it may have kept things, because you hear there's some of the guys, I don't know who these guys are, but they'll say, I've done my testosterone treatment and, my balls go up into my body. And, everyone's built differently. I guess everyone's anatomy is slightly different, but I've never seen that experience myself.
Oh, wow. I'd have to think about why theoretically that might happen. I'd be interested to see how people respond if that happened to them too. I can't think of
the fertility point of view. That's why Lipschultz had put that in the protocol.
Well, I can speak for sure, at least for one rationale, which is the one we mentioned already, gynecomastia. I mean, I was fortunate enough to round with him, which is not easy to do.
You actually know him. I just know from a paper, the name on the paper, you got to round with him.
But he definitely, will is a proponent of using, AIs preferentially. I've seen him use, but something to modulate the estrogen downward when the patient has gynecomastia. I mean, to me, it's just a no-brainer. Why wouldn't you?
What about the other cases? If you have an elevated prolactin level and a high estrogen level, would you feel comfortable offering that, or would you think going directly to fixing the prolactin problem only is the best way? So would you use like a DIM or calcium D-glucarate, or go right to
I don't mean to dodge the question.
Sorry,
but I
didn't mean all that.
No, but it's a great question, but I think we're getting into more of the nitty-gritty where I'd have to feel safe in answering that. I'd want to see the whole page.
All the patient, yeah, it's quite hypothetical. Yeah,
hear more about the history. How long has this been going on?
Yeah,
if there's high prolactin, just to throw something out there.
fair enough.
High prolactin because of
because you have just one single test.
Hyperammonoma.
Yeah,
And okay, we're going to deal with it totally differently, possibly.
Right.
Because it might require just a quick
Yeah,
and easy surgery.
yeah.
But a common surgery, and then we don't even have to think about the prolactin anymore. So
No, that's fine. That's fine. Do you see that often in patient groups? Elevations, a transient rise?
Too often, you would think.
Yeah.
Well, I see. Are you talking about prolactin?
Prolactin.
Oh, absolutely. I see it a lot. As a matter of fact, I stopped getting prolactin assays because of it. Why? If you look into the research, people on TRT, at least the dosages I recommend, along with Lipschultz and others, will have slightly elevated prolactin very often. I would say probably, I used to be an accountant before I was a doctor, so I'm presumably honest and conservative, right? So to try and err on the side of conservatives, I'll say 40% of the time. But that was enough to drive me crazy, and the patients too, and the practice. Doc, do I need cabergoline? I have a prolactin issue. And of course, they confuse the prolactin issue, as it were, with endogenous production versus you're already on TRT. So no, it really doesn't make a difference anyway. But again, if you look at the research, elevated prolactin mildly, so like, you might see a 16 or 18. Yeah. I've seen it as high as 21, but non-consequential, at least in terms of the patient function and feeling. one on TRT. Interesting.
TRT, yeah. Okay. But
Totally different circumstance, I would say, if it's, a patient that is dependent upon his endogenous production.
and were they on other medications like SSRIs or proton pump inhibitors?
State that across the board, including Nandrolone. Yeah. By the way, in terms of that, I'd be interested to hear your findings on this, Doc. I've had patients come in, not a whole bunch, but I've had bodybuilders that have used Nandrolone and are on, a couple of cc's of Nandrolone a week, which is much higher than the therapeutic dose, obviously. And, they're complaining about nipple sensitivity and some gynecomastia early stages. And they say, yeah, Doc, I need some cabergoline. I said, whoa. Let's look at bromocriptine. Let's look into this. No, I know it's prolactin. It's got to be the Deca, the Nandrolone.
Yeah.
And
Are they using testosterone as well?
yeah, using testosterone as well.
Abusing.
Probably, because they're using too much Nandrolone, they're using too much testosterone these days. That seems to be the way they do it, which that's a whole other topic of why you do that. I don't understand it. But anyway, I've won every single bet. I say, hold on, I will pay for your labs. If when we get them back, you have high prolactin and your estrogen is not high.
Yeah.
I won every single bet, never had to pay for the labs, because it is high estrogen that they didn't figure into the equation because of just what you mentioned. They double or triple the dose of testosterone, and they don't realize that that's what, it's converting to extra.
Testosterone is more estrogenic than Deca, right?
Of course. Yeah, way more.
And I think Deca can also lower your SHBG and maybe give you more beta.
It's not strong. It's not strong androgenic, the Nandrolone. It doesn't bind as DHT to the SHBG. Does it?
The
Nandrolone, does it lower the SHBG? Does it bind tightly to the SHBG?
Again, SHBG is not my bailiwick because I don't typically get it, so I don't observe that. But I know that, it's purported to be non-aromatizable. But I think some of the studies show that as much as, not frequently, but as much as, whatever that means. So once in a blue moon, it can be 20%. But mostly I don't see a lot of conversion of Nandrolone into estrogen from what I can tell. It's usually they also add the testosterone and forget, that can convert now, all that extra testosterone.
I think, sorry to me. Speaking of Nandrolone, Deca, I guess the brand name, we had a question from the channel from one of the people that left a comment. They wanted me to ask you about a Deca-only version of TRT.
No way. Actually, some TRTs was replaced for Nandrolone.
DRT, right? DRT, exactly, or NRT, right? Well, that's interesting because in my day, remember, I'm going to be 62 soon, guys. For various reasons, not available. We just didn't think this way. We would use the anabolic steroid and would not use testosterone along with it, and got great results. And for women, it happens to be a great choice, as is oxandrolone, because it's very weak as an androgen, converts to dihydronandrolone, not DHT, and so very few side effects. And you don't have the conversion into estrogen except for rarely a little bit. So I've seen women that use a very small dose of Nandrolone, particularly like I had a patient
for the bones.
Can help with bones for sure. I mean, all the testosterone, all the androgens. People talk about estrogens. Well, how about testosterone, guys? And of course, you still got to do the weight bearing exercise. But I had a patient that had a post-COVID issue and was losing weight very rapidly. Oxandrolone wasn't going to do it. She had some GI issues, so Nandrolone was a great choice.
Doesn't affect the lipids as animal, right?
It does it as much. That's true. Yeah, I would say. I'm glad you said that, George, because these are things that we observe through through the practice. Because I would agree with you. In my, again, just observations, not a study. It doesn't tend to affect the lipids as much. They all do, right? But I mean, certainly, stanozolol just destroys your HDL. Yeah, oxandrolone. Not as much, but still. But Nandrolone, I don't see it as much at all.
Yeah. I mean, George tells the story of his 108-year-old grandmother.
Yeah, I mean,
with prolactin.
She died 106. When she was 104, she got pneumonia. She has to be hospitalized. So me and my sister, who's a pediatrician, escaped from the traditional medical rules of the medical board and the hospital. I mean, my brother-in-law, she's married to a cardiologist who has no clue about that. So we're injecting her for 2 years, 100 milligrams of Deca every other week. No bone fracture, no cellulitis, hematocrit 41. And she was able, of course, to do some physical therapy. And she survived for 2 years, yeah. And, of course, with a plethora of other supplements, that was something miraculous to her.
And that makes sense, right?
A little bit of mustache,
No.
Great.
That is a great story, but that's, and I think I did put that in my book, is that, and not that I don't even want to make reference to the book. I just want to make it sound like I'm being repetitive, but anabolics, they got such a stigma attached to them.
Were made for elderly people.
It is absolutely perfect for elderly patients, right? Because that's when you're lacking in muscle. That's when it can be life-saving. I mean, God forbid, pneumonia is bad enough. I mean, typically, right, the typical patient, your grandma's age, would fall, break her hip, be hospitalized and get hospital-acquired pneumonia and die because of that, okay? So why not protect against that kind of fall, that kind of trauma resulting from fall, which if you look at the stats, I want to say it's like the third leading cause of accidents, fall, stuff like that. But that doesn't factor in, because if you don't die from the fall within 3 days, at least in this country, it's not counted as death from the fall. You die a month or 3 months later from hospital-acquired pneumonia, and that doesn't count as an accidental fall. So what I'm saying is the numbers are probably higher. So that's a perfect way. I mean, I'm glad you told that story. That's awesome. It amounts to 50 milligrams a week. That's a hefty dose too for, so you don't use that a higher dose for a 104-year-old. I could tell you a quick story if it may. You can always edit this out, right? But when I first started, I had an 83-year-old woman. I had an office in Whittier, and her chief complaint was, lack of energy, wanted to move more. She already, for her age, had plenty compared to most. But, again, it should be compared to yourself, right? But her main thing was she wanted to have energy to garden more. Great. But I was young. It was early in my career. I didn't know as much as certainly I know now, I hope to think. So I started on 15 milligrams per ml of a transdermal each day. 6 weeks or so later, she comes back in when it should have kicked in. And she started, actually it was 90 days, and she complains, I don't notice any difference. And I go, oh, I'm like, okay, because, this is my first failure, so to speak. And I said, well, I started on 15, we can go up in dose and go to 20. She says, what? Why did you start me on 15, not 20? I'm like, well, you're 83. She was pissed, and I understand why, because she's 83. It's not like time is is not of the essence. She doesn't have abundance of it, and she didn't get to the garden. And I learned my lesson early on that you can use, at least what I found, and you can tell me if you found something different. It's not that you're using the same dose for everybody. A standardized starting dose is okay. Just because you're older doesn't mean you can't benefit from it. Okay, now if you had kidney disease, if your grandma had that, then you have to factor that in terms of the metabolism of it. But you can still use a hefty dose.
The older you are, the GFR lowers according to the formula, because you implement also the age.
Of course. Yeah. So that's a great story to hear, that you can use that much. That's a hefty dose of Nandrolone, arguably, per week, right? Yeah. And it worked.
So you would.
She made it another 4 years, and it wasn't just like 84 to 88; it was 104 to 108.
That's fantastic. Yeah, I guess that's the story of a monotherapy Nandrolone story. I think traditionally it's used as an adjunct with TRT when it is used. Though I think in the late 90s or the early noughties, there were some studies or thoughts that because of the potential side effects of the prostate of testosterone. No, I know that Nandrolone would be used as a cell therapy to avoid the traditional side effects of testosterone, just like they had started developing those SARMs, which really. What's the point? I mean, I think, right, that was, but remember there were some papers about Nandrolone being used as a sole form of hormone replacement for.
The one case that's practical that I can mention where it would make sense certainly to use testosterone is that because it converts to dihydronandrolone, and DHT is essential for many men for erectile function.
Yeah, exactly.
You have enough testosterone on board. Typically a 1-to-1 ratio is good enough, but if you have a problem with that, you go to 2-to-1, and typically 100%, almost 100% problem solved, because your body still makes enough dihydrotestosterone to avoid erectile.
Hypogestational activity, and I say progestins also perhaps would be side effects of the cardiovascular system. Or assuming it absorbs the calcium, the Deca, and improves the bone mineral density, then in the long run maybe do some calcification in the endothelium.
Well, what about some of the water retention that one gets?
This is beneficial for the joints, though, because it kicks aldosterone and everything.
But does it make the heart work harder, having more fluid build up?
This goes to individual studies. Starting with the calcium, I mean, there's no doubt with anabolics or even testosterone, your body's going to absorb more calcium so-called natural that way. In other words, on TRT, such that even when I give Myers cocktails here, which tend, it's the kind of the cocktail today that has sort of everything to get started with, I pull the calcium out because typically you don't need it. I recommend not supplementing calcium for most people on TRT because your body hoards it. The key, if you want to make use of it, what I found is to make sure they get on D3. So you have the brick and mortar, but you also have the contractor to make it work.
D2 also.
Yes, so direct, yes,
To the
away from the vasculature. That's the current theory, right? But in terms of the aldosterone, who knows? And maybe who cares for someone who doesn't have CHF? What do I care about it? My blood pressure is maybe low. And the cool thing about Nandrolone, again, going back to Lipschultz and Baylor University, where he works, and one of my colleagues, he works here, Dr. Todd, is they used, and it was an 8-week study, it's published, Nandrolone for refractory joint pain. And it does work, but it doesn't necessarily work for a physiological reason of repair. Well, that makes sense to me because it's the first time I've heard that introduced as a possible additional reason, but we know that it works on pain. Yeah, we know that it definitely works on pain. The conversion of, I'm not going to remember it exactly, so I'm not going to say it on camera, but because I don't want to be misquoted, but there is a pain mechanism involved, which arguably is very, very helpful for another reason that, okay, say it's malpositioned the shoulder. A lot of bodybuilders, they work on the pecs too much, and so they're protracted, right? And so you work on, because you can now get through a workout and do the work to do, say, teres minor work, you can pull your shoulders back. You can do some work to, pull it back by, using some rhomboid training, lower trap training, whatever it is. So indirectly, you're helping through the pain management, but it also makes sense to get some fluid in the joints. If you're raising the aldosterone, that's something I hadn't considered. It makes sense.
Kick on EPO and hemoglobin when you implement also Deca along with testosterone. So you raise
it. Should raise anything above a standard TRT dose, with or without sleep apnea, is going to raise your H&H a bit. Yeah.
I mean, what are your thoughts on the elevation? I mean, there are some talks in the area that erythrocytosis secondary to TRT is not the same as polycythaemia vera, which is not. Polycythemia is absolutely not. Yet many of the traditional insurance-based doctors will conflate the two.
No, it's about the blood,
and they always mix it up. So, what are your thoughts on blood donation or managing hematocrit and hemoglobin? How important is it from your?
How often?
Well, what I have found in my practice, is that with very few exceptions, the elevations in hemoglobin, hematocrit, and red blood cell count are secondary to sleep apnea that's left untreated. And when you introduce testosterone, especially for someone who has had less than optimal levels of testosterone, which is required for the manufacture of a red blood cell and the hemoglobin thereupon, all of a sudden you see this rise in hemoglobin and hematocrit, which has been countered by the fact that you didn't have the testosterone. So, of course, the primary care physician goes, see, I told you it's that damn testosterone that's causing this. Well, it's not. It's leveraging it, and it's the sleep apnea. And 100% of the time, except for a very, very rare gene mutation, a JAK2 gene mutation, it's because of the sleep apnea that when treated properly, because we had this discussion at lunch, CPAP doesn't always work. It's one of the worst solutions, unless you're 350 pounds, you have no other choice, but to shove air down your airway as a resolution. But if sleep apnea can be properly treated, successfully treated, the H&H goes back to quote unquote normal within normal limits. It's not the testosterone that's the problem. That's what I found across the board. Now, when it comes to blood viscosity, if you go into the physics of it, we talked about this a little bit last time. I would love to be a physicist if I could have, if I had the smarts for it, number one, and I could have made a living at it. But there is a correlation between viscosity and stickiness, but they are not the same thing.
Yeah.
Okay. Yeah. But most people treat it that way, including even some hematologists. So, oh my goodness, well, you're at risk of death because your hemoglobin is 19.5. Well, tell that to all the people that are in Aspen, Colorado, that come to see me there. I have an office there, and I see it all the time in the mail.
Those people adjust.
Of course they do. If not, they'd be not having a good time living at 8,800 feet all year round, right? So I call the you know what, flag on that one. Okay. For that just practical sort of, I'll call it an obvious, well, that doesn't make sense. But also there is a difference between stickiness and viscosity. Now, if the blood is so viscous that it slows the progression through the vasculature, it makes sense. I use the example like you have two magnets. Well, if you go like this really fast, they're less likely to clump together. But if you go like this, then you have a chance for them to stick, right? That's as close as I can get without getting into the true physics of it, to say that, yes, there's a correlation, but not like the doctors assume. I've seen patients with true autoimmune polycythaemia rubra vera that have H&H numbers that you go, that's not possible, that are walking around doing fine. I see them at Gold's Gym a lot, and they're doing
the key
fine.
factor is the platelets, the thrombocytes should be kept low.
Well, the key factor to me is, well, that obviously comes into play because that's more to do with the stickiness, right? But to me, it's, does the patient have any side effects? Because I don't see 21s and 23s in terms of hemoglobin often and commensurate hematocrits. What I see is typically somewhere between, say, 18.5 hemoglobin. I'm just using that because it's an easy number. Again, for the audience, you multiply times 3 roughly to get a hematocrit that's commensurate. But 18.5 to 19.5 is when symptoms occur. So that you get up out of a chair, and it takes an extra beat or two of your heart to get the blood from your legs to your head. And you go, whoa, I kind of feel dizzy. And it's not because you have a low blood sugar or you're dehydrated. Your blood is viscous, though, because you have too many of these red blood cells.
If you like content like this, do click like and subscribe and hit the notification bell if you want to get our latest updates for when we drop content. It really does mean a lot. And until next time, to your wellness, this is Mike.